Good afternoon, everybody. Welcome to the meeting. Special word of welcome to the students who's also joining us from CPUT. We're very glad to see that you didn't seem to have any problems today. I apologize for the last meeting, the problems that everybody experienced. Hopefully it's a thing of the past now. We will see how today goes. Okay, our cameras and microphones are switched off for attendees. It's just to make sure, because there's so many people in the meeting, it's just to make sure that there's no distractions during the meeting. And then also please remember, if you have questions, post it in the Q&A section, or if you can't find it, in the chat section, and we will make sure that it's answered after the presentation. Otherwise, if we need you to react, you're welcome to use the emojis that's available. Okay, I want to quickly share with you these where you can find the chat, where you can write down anything that you need to write down, and the Q&A is supposed to look like this. I know that it depends on the plan that you have. Not all of you will be able to see it, but I hope that you do. And if you've got any questions, please raise it in the Q&A section. If you see this icons that you see at the bottom, you will see that there's something that we pinned in the chat, and also there's something that we might pin in WhatsApp. The icon for the WhatsApp will appear there as well. Okay, let's start with the meeting. As I say, welcome to everybody. Our training topic today is respiratory impairment. The speaker is Professor David Rees, and I'm handing over to Lindy to introduce him. Thank you, Lindy. Professor Rees, you are welcome to share your presentation now.
Good afternoon, everybody. So while they are busy resharing and unsharing and again sharing, it is my privilege to welcome and introduce Emeritus Professor David Rees. David was a professor of occupational health at the University of the Witwatersrand, or WITS as we know it, as well as the director of South Africa's National Institute for Occupational Health, or NIO as we know it, and as well as the head of occupational medicine and epidemiology. I see that Prof did his first degree MBBCH at WITS the year that I was in grade 1. So there is so much experience coming to this talk, and I'm so looking forward to it. So, Professor Rees, welcome, and thank you for joining us and sharing your knowledge with us.
It's a pleasure. Good afternoon, everybody, and thank you for the invitation to join you. I think many of you, most of you maybe, will have more direct occupational health experience working in occupational health services than I have. I mean, I worked in a sort of referral and tertiary setup for most of my professional life. So I'm going to try and finish with enough time so that you can contribute and add your comments and additions to what I've got to say. Yeah, so I'll try and finish with enough time for that. Lindy asked me to try and do a case study, but I think there are too many issues really to cover it in one case study. So some of it's a bit didactic, but I've tried to introduce case studies into some of the elements of it. I hope this is sharing.
Yes, it is, Prof.
Okay, great. All right. So as Lindy said, I'm talking about, or Janet, I'm talking about respiratory impairment in the workplace. And these are the issues Lindy asked me to cover, which I will do, except for the last one, when is removal from exposure necessary? Well, I will cover that, but I'm not going to cover the processes and procedures because, frankly, I don't have that much experience of them, and often they overlap with HR. So I'm not going to talk about the processes and procedures. I think many of you will know more about it than I do. So, but before I go into those issues, there's just some preliminary things I wanted to talk about. And one is spirometry itself. Now, this is key to respiratory impairment spirometry. And I know most of you or all of you know what the basic spirometry parameters are, but I thought I would just remind some of you who might not deal with spirometry every day. So the most important parameters are the FVC, that's the forced vital capacity. It's the amount of air you can breathe out after a maximal inhalation in a forced expiration. So it's kind of a measure of how large your lungs are. It's an indirect measure of how big your lungs are. And the FEV1 is the amount of air you can breathe out in 1 second after a maximum inhalation with a forced expiratory maneuver. So you're breathing out as hard as you can, and you measure how much air comes out of your mouth in the first second. And then there's the ratio of FV1, FVC, which is really a measure of whether you have obstruction or restriction, which is a small chest. I know almost all of you know this. The picture there is a volume time curve. And in any event, I'm sure you're familiar with it. But one of the things I wanted to say is that spirometry is really key and often the only test that's available, but sometimes the DLCO is important. That's the diffusing capacity for carbon monoxide. It's a measure of how gases move from the lung into the blood and from the blood back into the lung. And basically, that's what the respiratory system is supposed to be doing. So it's a really cardinal feature of respiration. And in cases where there's a discordance between dyspnea, shortness of breath, and the spirometric parameters, that's when DLCO becomes particularly useful. So you get some patients who are quite short of breath, but they have relatively normal spirometry. And that's when the DLCO can be really useful. And it's why in many respiratory impairment systems to quantify respiratory impairment, the DLCO is one of the parameters that's measured. Okay, the other point I wanted to make is that impairment is not disability. So this is a case, the current case that I'm involved with. So it's a coal miner with simple coal workers pneumoconiosis. So that's the sort of nodules that coal miners get from fibrosis due to coal mine dust. The person has no symptoms and no lung function impairment. You can see the, if you look at the bottom of the slide where the lung function values are shown, the FVC is 92% of predicted and the FEV1 also 92% of predicted. So the lawyer representing the coal mine where this worker was working said, well, there's no impairment, there are no symptoms, there's no lung function impairment, so no harm's been done to the person. And so really there's no liability. Well, I don't know what you think about that. Some of the slides I've got questions, but they're really for you to think about and then think what do you actually think about this, not to answer, of course, because we don't have that capacity. So what do you think? There's no harm being done because the person has no impairment, really. Well, my response to this was that harm has been done because the person has disability, and that the disability is the effect on the person due to the physical condition or the disease. So it's a more global assessment of what this means to the person. And of course, in a case like coal workers pneumoconiosis, you could be retrenched, you could be transferred to a lower paid job. So there's potential loss of income. In, I suppose, well, something like the worst case scenario, there might not be any low exposure jobs and you may be retrenched and end up unemployed. And the key thing about unemployment that I think many people don't appreciate sufficiently, employers and us, occupational health people, is that it has quite a profound impact on mental health. There are quite a few studies. There's one at the bottom of the slide. Um, not such a recent one, but it's sort of an overview of mental health impairment following unemployment. And it can be quite profound, and that can affect the person, but also very much the person's family. I mean, well, anyway, you would understand that. And of course, if you have a condition, this is the third point I'm making, it can reduce your employability. If you pitch up at a pre-employment medical, for example, and you have an abnormal chest x-ray, your chances of getting employed might be reduced. So there are also other things about disability. I mean, it might interfere with your quality of life, for instance. Well, there are many ways it might interfere with it. So the point I'm making is that low impairment or mild impairment does not necessarily mean no disability. The other issue I wanted to touch on in a preliminary way is the spirometry reference values. So as you all know, when you looking at the values you get from spirometry, the actual liters, you need a reference value to see if it's normal, impaired or not. And so the reference values that are used for this can make a difference. For example, this is an example of a 60-year-old African man, 175 centimeters tall. Now, the reference values I'm showing here are the ECCS reference values, so the European Community for Coal and Steel, and they've been very widely used in South Africa. I don't know how widely used they still are. They shouldn't be widely used, but they were certainly very widely used. And it was common practice when they were widely used, and maybe still common practice today, I don't know, that for African subjects, you would use the ECCS reference value. That's what the equation actually says what the reference value should be, and then subtract 10% for African subjects. So it would be 10% smaller than the actual predicted value. And that was because the ECCS was derived using white European workers. I mean, European in the sense that they worked in Europe. So now let's say, for instance, this person must have 80% predicted FEV1 to get a job. So that's one of the entry criteria. It's an entry criterion. 80% of the ECCS minus 10%, I worked this out using the equation, is 2.37 liters. The actual ECCS value is 2.64 liters. So if you use ECCS minus 10%, it's actually easier for this person to get the job because they can get into the job with a lower FEV1. On the other hand, if you can only get compensation, or not only workers' compensation, but let's say like the CMESO Trust or whatever kind of benefits, financial benefits might be available, maybe you have to have an FEV1 below 10%. Then if you use the ECCS without the 10% correction, it's easier for you to get compensation because that's 2.64 liters. It means, you can have less of a smaller FEV1 and still get the compensation. Well, it's harder if you use ECS minus 10% to satisfy the compensation criteria. So it does make a difference what reference values you use. And I just want to leave you with one message, and I'm probably you know this already. The ECCS minus 10% approach has been strongly discouraged internationally and locally now. And the GLI, the Global Lung Function Initiative reference equations, have been widely recommended. They're endorsed by South African Thoracic Society and SASOM. And for African subjects, one should use the GLI other. It's an option in the GLI equation. So it's a simple message, really. We should be using GLI now and not ECCS. Clinical assessment. Well, I said that spirometry is key in assessing respiratory impairment, and it is, but there are occasions, not that infrequent, where the clinical assessment can be important. So here's an example. When I say the clinical assessment, I suppose I mean clinically and also a holistic look at the person. So this was a worker with an FEV1 of 55% of predicted, doing sedentary work in an office, filing or whatever, and can cope with the physical demands of the work, but is unfit for work in the sense that he or she is unable to deal with working. And my question is, well, what could the reason be? Of course, there are many potential reasons. Comorbidities might be a reason, but in this case, it's not comorbidities. The person doesn't have any cardiac problems or anything else. So what might the reason be? And in this case, it's travel to and from work. And this is quite an important consideration. So, I mean, you can imagine a person, a worker, living in a township quite distant from the workplace, quite far from a taxi rank, maybe having to walk to the taxi rank, catching a taxi, being dropped off quite far from the office where he or she works, maybe having to walk upstairs to get to the office, and the person just can't cope with the physical demands of getting to and from work. So it's not only about being able to deal with the job at work. Another example is asthma. So just think of this case, a 39-year-old woman on treatment for asthma. Her FEV1 post-bronchodilator is 76% of predicted, which is pretty normal, really. I mean, if you take 80% as normal, or the lower limit of normal, but let's just use 80% to illustrate the case, 76% is almost normal. So the question is this mild impairment, let's say for assessing workers' compensation claims or other instances? On the face of it would seem so. But if you look at her medication requirements, she has twice daily inhaled long-acting bronchodilator and high-dose steroids, pulses of oral steroids about 5 times a year, and emergency room treatments about 3 times per year. So quite intensive treatment. Now, what does this mean in terms of respiratory impairment for the COID Act or potentially other benefits, financial benefits? So these tables are from the circular instruction on occupational asthma impairment. Table 1 shows the impairment score based on the FEV1, and this case would be a score of 1. Between 70% and the lower limit of normal, or let's call that 80%, so 76% is a score of 1. But when you look at table 2, the medication score is actually a score of 4, which is daily bronchodilator and all of the other things, and high-dose inhaled steroids and frequent systemic steroid use. So what does this mean? Well, that turns out 4 for medication and 1 for FEV1 is a score of 5, which is 50% permanent disabled in terms of COID Act. So it's certainly not mild. This would mean a pension for life, basically. So, I mean, the point is it's not just about the FEV1. So I'm just making the point that spirometry is key to respiratory impairment, but it's certainly not the be-all and end-all. Asthma, for instance, you want to look at medications. COPD, exacerbations are important. Exacerbations are acute worsening of COPD. It's usually caused by respiratory infections, and it has quite an impact on quality of life and progression of the COPD. So it's well, in recent times has been included in the assessment of the severity of COPD. And there are also individual variations, which means that the FEV1 or the spirometry might underestimate the actual impairment that the person experiences. And there's quite a lot of individual variability around that. So just to summarize that spirometry, it is the key tool in respiratory impairment and in many respiratory impairment grading systems, but it's not the only important aspect. DLCO can be important, and that's why it's included in many impairment grading systems. And I'll just show you a couple. I think probably the most commonly used system for grading respiratory impairment is that of the American Medical Association. They publish periodically guides to the evaluation of permanent impairment, and they're used all over the world. They run very expensive training programs all over, including in South Africa, on how to use the system. In any event, this is a table summarizing how you do, how you grade pulmonary dysfunction or pulmonary impairment. And look, I'm just showing you this to give you an idea of how these systems work. I mean, I don't remember this. I have to look it up every time I use it. But I'm just showing it to you to give you a sense of how these systems work. They do include history taking and physical findings, but really they're very peripheral to the determination of the impairment. And by the way, you can see, oh, how did that happen? You can see they're graded into minimal impairment, mild, moderate, and severe. But the heart of the matter is really the FVC and the FEV1, and sometimes the DLCO, as we've discussed, becomes important if it's available. It's not a desktop lung function tool. Well, actually, there was talk of it becoming a desktop tool, but it's quite a sophisticated measure, and I think in the main it's limited to lung function labs, so it's not that freely available. And yeah, but if it's available, then it can be important. All right, so that's one example. This is how COPD impairment is graded, or severity is graded. It's from the Global Initiative for Chronic Obstructive Lung Disease, GOLD, which is sort of the Bible of COPD. Every year they publish a very large document on COPD, and it's the gold standard for everybody, really. Anyway, this is how they grade the severity of COPD: mild, moderate, severe, and very severe. And you can see it's based largely on FEV1. And the reason I'm showing this is almost all patients with COPD, if they've seen a pulmonologist or a physician interested in COPD, will have this gold grading. So they'll write a report saying this person has COPD gold class 1 or whatever. So it's useful to know where it comes from. I did say that they use exacerbations as well. So in the gold system, they also are testing a system that incorporates exacerbations. This is how Dimwa grades impairment. I'm just sorry, part of the screen is obscured by the participants, but it's okay. So in the ODIMWA, Occupational Diseases in Mines and Works Act. Sorry, my phone's ringing. I'm just turning it off. There are 4 classes really: normal, mildly impaired, moderately impaired, and severely impaired. Both normal and mildly impaired are NCD, in other words, non-compensable disease. Moderately impaired is first degree and severely impaired is second degree. And that determines the amount of money you get, as I'm sure you know. Second degree gets more money. And it's quite strict in many senses. So you have to have, for example, an FEV1 below 65% of predicted to become first degree. If you have an FEV1 of, let's say, 67% of predicted, and you have, let's say, silicosis, you're not going to get compensation because you don't satisfy the impairment criteria. I've put an arrow there at FEV1, FEC. It's not actually used anymore. It is part of the documents that you might see, but it's not used anymore because it really it's not very helpful in assessing respiratory impairment. Okay, turning to respirators. I want to cover 2 things: the capacity to use a respirator and respirator fit testing. But before I do, I just wanted to touch on nomenclature, because when we talk to each other, we need to use the same. We need to understand the words that we use in the same way to communicate effectively. So, what would you call the thing on the top? The protective device on the top, and what would you call the protective device on the bottom? Now, I'm not asking you to say specifically what it is. It's just in general, the general terminology for the thing on the top and the general terminology for the thing on the bottom. Well, the thing on the top is a mask. It's a surgical mask in this case. And cloth masks and surgical masks are masks. Everything else essentially is a respirator. So N95s, KN95s, FFP2s are respirators. This one at the bottom is actually an N95 respirator. And the distinction is quite important because a mask is really to protect other people. For example, during COVID, wearing a cloth mask or a surgical mask was to prevent viral particles infecting other people. It wasn't to protect the wearer, really, although it did offer some protection, but not much. Whereas respirators are to protect the wearer. And just in passing, there's been quite a lot of research on the KN95 respirators, and they just really aren't that good. They don't work that well. I think they still attach over a person's ears and not over their head. And that means that they're just not that effective. Whereas the N95 respirators actually go over the head and they just fix more closely to the face. Okay, so fitness to wear. Let's say we've got 2 workers and they have the same job. Both have an FEV1 of about 65% of predicted. The man on the left can tolerate a respirator, and the one on the right cannot tolerate a respirator. So what do you think the possible reasons might be? Well, there are potentially a lot of reasons. There are many factors, usually divided into workplace factors and individual, not only psychological, but individual physical and psychological factors. And the workplace, it might be the physical demands. If you've got a really physically demanding job, it might be more difficult to wear a respirator. Also in heat and moisture. I remember during COVID, there was a lot of talk of miners going underground and working in an environment that was hot and had a lot of water because the drills were, using water to dampen the dust. And so there was a lot of moisture and a lot of heat. And I mean, it was a lot of discussion about how people are going to wear respirators all the time to avoid COVID. I mean, they would have been wearing respirators anyway in some instances, but anyway. Also, sometimes it's difficult to wear respirators when your work demands make it difficult, and the type of respirator is important. And individual factors, other morbidities besides respiratory, might be important. I've mentioned cardiac, but also chronic bronchitis, which is a chronic cough and sputum production. You can just imagine if you having to wear a respirator and you've got a coughing sputum into the respirator every 30 minutes or so, it's obviously going to make it very difficult. But there are lots of psychological call them psychological. Some people just experience claustrophobia when wearing respirators, and they can get anxious. And there was a suggestion that every occupational health person should wear a respirator for 8 hours just to see what it feels like. And I did try it, and I must say, it's not that easy. It's also interesting that feeling short of breath is something that varies a lot among individuals. Some people perceive dyspnea much more easily than others. So they've just, it's a sensation and they just sense it more than others. So in terms of that example of those two people, the person on the right happened to be smaller and less fit and less strong. And so for the same work, they had more effort and more breathing, and therefore it was difficult for them to wear a respirator, more difficult than the other person. So one has to think about individual factors when thinking about whether a person's going to be fit or not. There is a general guide about this. It's an ATS guide, American Thoracic Society. In the United States, anybody who's going to wear a respirator, I mean, I don't know how widely this is applied or adhered to. I don't know what the compliance is like, but people are supposed to have a medical evaluation for fitness to wear a respirator. Anyway, the ATS has given a general guide that people with an FEV1 greater than or equal to 60% of predicted can be expected to be able to tolerate a respirator, given all the other workplace and individual factors that I mentioned. This is a guide, it's not a rule. And what they recommend is that where it's not, let's say it's a borderline case, you may need a trial to see if a person can tolerate a respirator and what kind of respirator they can tolerate. This ATS guide was actually, it's called Respiratory Protection Guidelines. It's a very good document, but it was published in 1996, and as far as I know, there hasn't been an update. I did look to see, and I couldn't find anything. Maybe one of you know of a more up-to-date publication on this issue, but this is I've used this for a long time. It's very good, even though it's a bit dated. So what about fit testing, which really is a measure of whether the respirator is doing its job? In other words, stopping hazards penetrating through the respirator or around the sides of the respirator and entering the breathing zone. Fit testing is not mandatory in South Africa, although it is recommended, but it is needed. Face sizes and shapes vary, and there's no such thing as one size fits all for respirators. I really didn't have much of a sense of this when I first started working with fit testing. I mean, I thought it was a sort of bit of a luxury add-on, but actually it really is important. Um, um, I just wanted to show the study of 506, well, some results from it. 562 respirator using diagnostic laboratory employees, actually the NHLS. The study was done by Janeth Manganye. It was her MPH research report study. And she went and did fit testing on these diagnostic laboratory employees while they were using the respirators that had been issued to them. And remember, they're working in a quite hazardous environment, respiratory infections and TB and all sorts of other things. So here's my question. What percentage of these respirator using lab workers would you expect to have failed the fit test using their currently supplied respirators? Maybe you can think of a percentage in your mind. Well, the answer is, where that arrow is, 78% of the respirator users failed the fit testing. In other words, their respirators weren't working optimally and they were potentially at risk. I mean, the respirators were offering some protection, but not adequate protection. 78%. And these are people who are working, you'd think they'd be pretty good at wearing respirators. There's the reference to the article if you're interested. So there are many ways of doing fit testing, but I think the quantitative measures are best. Some of the qualitative ones, for example, is you put the person wears the respirator and you expose them to a chemical that when they breathe it in, they can taste it in their mouths, and then they just say, "Oh, I can taste it," and then you say, "Well, the respirator isn't working." But there are quantitative ones that give you an actual measure of how effective the fit is. And the NIOH uses this. This is quite a common one. It's the porta count respirator. We're surrounded by particles in our environment. I mean, they might come from car exhausts or general dust or pollen or whatever. So there are particles in the atmosphere that we breathe all the time. So what this piece of equipment does, this piece of kit does, is that the person wears their respirator, you put a probe through the respirator into the breathing zone, and you measure the particle concentration in the respirator relative to the particle concentration in the environment. And that gives you a quantitative measure of how the respirator is working. As I say, this is the equipment the kit that the NIOH uses, and it's quite widely used. Okay, workplace accommodation. As you all know, the Labour Relations Act mandates reasonable accommodation for employees with disabilities. I've learned over the years not to talk about the law much because it evolves. I mean, there's case law coming out all the time, and there are a lot of nuances and subtleties to interpretation of the law. And so, yeah, one has to be a little bit careful if you're not intimately involved with the law regulation or whatever. So all I'm going to say is that it mandates reasonable accommodation, and what reasonable accommodation is the subject of much case law. And there's an increased onus on employers to try and do reasonable accommodation when there are occupational injuries and diseases. Now, I just want to leave you with one message, which I will illustrate with the next couple of slides, is that respiratory impairments can be helpful, but there's a large individual variability for many reasons. And so one needs to assess case by case about workplace interventions. And I wanted to use the example of work-exacerbated asthma. So I'm sure you know that work-related asthma is divided into occupational asthma, that's asthma caused by work, and work-exacerbated asthma, which is asthma that's just made worse, asthma that the person already has. It wasn't caused by work, it's just coincidentally that the person has asthma, and something at work triggers the asthma and makes it worse, generally meaning more symptoms and more medication requirements. So here's an example of a case I saw. This is a 38-year-old man. He worked in a water treatment plant, adding chemicals to pools of water. It was when I saw him, he'd been doing this for about 10 years. He was asthmatic on treatment, and he was diagnosed, before he started work at the water treatment plant. So he was an asthmatic already. And he had asthma triggered by workplace exposures, and this has resulted in him having to increase his medication. So how does one approach this in terms of workplace accommodation? Well, one needs to think of the accommodation at work, but also more holistically. And this is often the case when you're thinking about workplace accommodation. It's not just about the workplace, it's about the person in general. So for asthma, you would optimize treatment, try and reduce the troublesome exposures. And this will almost always has nothing to do with the OEL. I mean, exposures below the OEL can be troublesome to asthmatics. But I think one of the important things to think about is this is not always feasible or suitable, but in this case was to try and allocate tasks that trigger asthma to co-workers. So this man, periodically during the day, a few times, used to take chlorine and put it into some of these pools of water, and that triggered his asthma, just that task. And so it was quite easy in this case to allocate that task to somebody else. One would also want to identify and manage non-workplace triggers. Asthmatics can be triggered by many things. I mean, perfume, cigarette smoke, filling their cars and things like that with fuel. And possibly think about a respirator, depending on the tolerance to wear the respirator. One of the things I wanted to mention is respirators in these sort of instances can be used intermittently. So you just give the person the respirator when they're doing, or the person wears a respirator when they're doing a particular task that triggers the asthma, providing it's not all day, of course. Okay, medical surveillance. So there's a difference between surveillance and screening. Screening is for individuals. I'm sure we've all undergone screening for various conditions. When you screened for a condition, it's really about you. If the condition is found during the screening, then steps are taken for you. Whereas surveillance is about collecting data to do something about it. So disease notification is an example of surveillance. I mean, many of the diseases we notify or supposed to notify are infectious, and the idea is to do something to protect the community. It's not only about, of course, you have to deal with the individual, but it's not only about the individuals using the data to do something. And this is very important for lung function surveillance. I mean, there are workplaces that do spirometry, measure lung function. It goes into the patient file, and really that's it. What I think needs to be done and is important is that the decline in lung function needs to be evaluated according to tasks, work areas, similar exposure groups, etc. So to detect a decline in a group and then do something about the workplace exposures. Should the decline be occurring, let's say, in people doing a particular task. There are systems, electronic systems, to monitor decline in lung function. so that you don't have to do it manually. I'm not punting this particular system. They're much more modern ones, but this is, I just happen to have a slide of this one. This is Spiro Access. It's from 2007. I know they're better systems. But anyway, you could set the level of decline. Let's say you set it at 10%. And if year on year there's a decline greater than 10%, you would be, a machine would alert you to it. The system would alert you to it. So there are systems, and they're important. So here's an example. Now, the individualization of medical surveillance. So here's a 50-year-old woman, 20 years of silica exposure. She's got an FEV1 FEC of 65%, FEV1 74% predicted, and diagnosis of COPD. There are no unexposed jobs at the workplace. So what would you do if you found this on surveillance? Well, in theory, you should stop exposure because there's some evidence that continued exposure leads to a more rapid decline in FEV1 and worsening of COPD. But one of the things you can do, and one of the things that's recommended, is that the person can remain exposed, but you can enhance surveillance. So you do it more frequently and you pay more attention to it, and you monitor the decline in lung function. And if there's a steep decline, then you know you have to do something about it. So in other words, yeah, surveillance can be helpful to make decisions about things like that. This is the last topic. When is removal from exposure necessary? Well, there's no easy answer, and it's important to say that there's no general answer, because removal can mean financial losses, can even mean unemployment, and of course those have negative consequences. So one has to weigh carefully the negative consequences against the potential reduction of respiratory impairment. And one has to consider individual worker factors. So here's an example: a 62-year-old foundry worker with early silicosis and mild lung function loss, 40 years in foundry work. Do you remove the person to prevent progression of silicosis and deterioration of lung function? So the person has silicosis, working exposed to silica. Do they necessarily have to be removed from exposure? Well, you have to find out more about the person, I think. So this person has an unemployed daughter with 3 children, and they rely on him financially. He wants to work to 65 so he can maximize his pension. And this is the important thing to my mind. He's already had 40 years of silica exposure. He's 62. Is another 3 years going to make a difference? Potentially not. And we know that silicosis can progress even if you don't have continued exposure. So, it's not sure you're going to achieve much. The other thing, of course, is to look at the current exposure. I mean, maybe it was historically bad and now it's not so bad. And so, it's not necessary to remove the person. If a person's got a disease that's caused by an exposure and you're going to recommend that they stay exposed or continue to be exposed, you need to counsel them, of course, and get them to sign that you've been counseled. I was actually reported to the Health Professions Council of SA of South Africa by a person who had dermatitis. It was from platinum salts, and I talked to him and we counseled him. And in the end, I decided, look, why don't you stay exposed, and then let's see how your dermatitis responds to treatment and other things. And actually, his dermatitis got worse, and he reported me to the HPCSA. But luckily, I had counseled him and he had signed that he agreed with the decision. So the important thing is, document that you've counselled the person and put the pros and cons to them. Removal can be inevitable, of course, and we all know this. I mean, I think, no, I don't think I'll go through this case, but I mean, removal from exposure can be inevitable, and it might be taken out of the patient's hands because there's just evidence that deterioration is going to occur and it's going to be severe, and you just can't continue the exposure. I wanted to make the point that this job protection issue around, and removal from exposure is a recognised issue globally. Queensland State in Australia has quite a lot of coal mining, and there's been an upsurge in coal workers' pneumoconiosis in parts of the world, including Australia, and so coal miners were developing coal workers' pneumoconiosis and then losing their jobs. So they put a commission together and they came up with recommendations about when people can still stay in work with coal workers' pneumoconiosis. And they came to a whole lot of recommendations and guides, but particularly it was around people can go back to work if you reduce the exposure. So I don't know if you can see this. In this case, they said that if the respirable coal mine dust was below 0.5 milligrams per cubic meter, even if the coal workers' pneumoconiosis was quite advanced, people could stay at work. So they would have some risk of, worsening of disease, but the risk wouldn't be that high. That 0.5 is about our current mining coal mine dust OEL is 2 milligrams per cubic meter, but in many parts of the world it's 1 milligrams per cubic meter, so it's about half of some OELs around the world. Okay, so this is my last slide. The message about removal from exposure guides are useful, like that Queensland guide, but decisions need individualized consideration. And I think one needs to get information from workers and bear that in mind when coming to decisions. I know that's not always feasible in workplaces, but I mean, I think it is probably the ideal way to go about it. Okay, that's it.
Thank you, Professor Rees. I just want to ask from the attendees, I see we've got 101 people on this meeting. I have not seen any questions yet. I don't know if the rest of the committee maybe saw a question somewhere. If you guys can ask your questions in the Q&A section. In the meantime, I think, Professor Rees, that the whole picture that you've drawn here from the start to the end was a mouthful. We had a workshop in March about the Balancing Act, and I again got this feeling, from having a risk assessment, having the OELs, knowing the exposures, knowing your individual person with his individual susceptibility, in seeing the holistic picture is really a big job for the occupational health practitioner, if it now is the nurse or the doctor. And I agree with you that we are there to keep the people employed. I had actually had this discussion last week with one of my employees. If we're young, we just want to get to retirement age. And when we are retirement age, we do not actually want to retire, because we actually value how much work means for us, and not only financially. So thank you for sharing your expertise. It was really insightful. It seems that there are no questions from our side. I think you've gave us a lot to think about. So thank you, and we're looking forward to maybe another presentation in the future.
Well, thank you very much for asking me to join you. I hope it was some use. If you want, if there are questions, we can always think about them afterwards. And
Yes.
if people have comments, I'm interested to hear what your experiences are as well.
Yes, thank you. I will, if I do get any questions, we will definitely contact you. I think from the ECCS is reference parameters or values are still widely used in South Africa, and not the GLI yet. Not all the software is being updated, and they don't work with the latest technology. So that, I think, is one of the problems we currently face. If you talk about a Z-score, most people do not know what a Z-score is. So I think that is one of the bigger challenges with regards to the work that we do. But we will keep on informing everybody, and hopefully we will increase the standard in South Africa on spirometry, if I just focus on spirometry. But I'll definitely send the questions to your site. Thanks a lot.
Okay, great. Thank you very much.
Right.
Cheers,
Thank
everybody.
you. Bye-bye. Joannette, over to you.
Thank you. Let's quickly move over to the back to basics presentation. If you give me a moment, I want to share my screen. Okay, so Lindy asked me to say quickly something about health assessment and eye conditions. Oh, sorry, eye conditions. The health assessment part is just a by the way. Right, so let's quickly look at these the parts of the eye which we are going to refer to. Cast your eyes on it very quickly. Iris, cornea, sclera, and the pupil is one of them. Okay, and then very quickly, assessment of the eyes, apart from the vision screening and the cranial nerves that you need to assess with the eye movements. There's also looking at the eyes, the alignment and the position of the eyes, whether it's symmetrical aligned with eyebrow and maxilla, eyelids, droopy eyelids, ptosis, redness, swelling, lumps, discharge, uneven eyelashes. Eyelashes that's falling out is always an indication of something that is affecting the system. And then the conjunctiva is look for redness, ulcerations, and growths. The sclera, look at the color and even distribution. Oh, sorry, the color of the sclera, it should be white. The cornea, look for clarity and any growths on the cornea, and the iris and the pupil, look for even distribution of color in the iris and the form of the pupil. Now here's the conditions. First one is coloboma. It's a keyhole-shaped pupil, which is a congenital defect. It's where the tissues don't fuse when the fetus is developing in the eye, which causes a hole in a bigger hole in the eye than the pupil usually is. So it means that a part of the eye is a part of the iris is missing. It usually doesn't impact visual acuity, but it can increase the person's sensitivity to light. It can also affect other parts of the eye, such as the retina, optic nerve, or eyelids, and that may lead to more severe vision problems. Usually not a problem, but it needs further assessment if you see something like this. Okay, I had to Google how to pronounce this. They say it's pterygium. I hope I said that right. It's a fleshy growth on the surface of the eye. It's usually on the side of the nose, and it can extend onto the cornea. It's a benign growth, also known as surface eye, and is frequently caused by prolonged exposure to UV light, wind, and dust. So for all the people working outside, you might see this during your assessment. As I said, it's usually benign unless it obstructs the vision. Blepharitis is inflammation of the eyelids. In Afrikaans, we used to call this a karkaaitjie, that first one. Very painful. Often characterized by redness, scaling, and crusting along the eyelid margins, and as I say, quite painful. Usually resolves by itself after a few days. Really needs any active intervention unless it forms a wound on the eye. And then corneal arcus or arcus senilis, it's that white ring around the eye. It's about around the outer part of the cornea, which is the clear dome-shaped part of the eye. It's a common finding in older adults, and it's caused by fatty deposits, primarily cholesterol accumulating in the peripheral cornea. Right, so if you see this, it's an indication that this person might have high cholesterol, and it would be worth your while to advise this person to have it tested. Okay, jaundice, a very well-known one. It's a yellow discoloration of the skin and the whites of the eyes. They also call it scleral icterus. It's a symptom of elevated bilirubin levels in the blood, and it means that the liver isn't processing bilirubin. Bilirubin is a waste product from red blood cell breakdown. This is one of the examples that shows you that this is the systemic cause that you might have to investigate further. It's easy to see it in the eyes because the eyes are very white. So if there's any yellowing, you will probably see it in the eyes and the fingernails first. Conjunctivitis is very common. You get the infection, the pink eye, which is an inflammation of the transparent membrane. It causes redness, swelling, itching, and discharge. And it causes the blood vessels in the conjunctiva to become more visible, leading to the pink or reddish appearance that you see with conjunctivitis. The bottom picture shows you allergic conjunctivitis, which usually affects both eyes, and it is caused by eyes reacting to allergens like pollen, dust, or pet dander. For those of you in the Western Cape working with people in the Overberg region, you will, or near farms, you will probably see this during spring when the fynbos starts to bloom and the canola fields start to bloom, and when they start spraying all the pesticides. So this is usually when we see most of the allergic reactions, and allergic conjunctivitis is just one of the signs and symptoms. Okay, that was very quick. Did you learn something? Hope you did. There's one or two words that you didn't know that you know now. It was probably worthwhile. Thank you. Okay, let's continue with our meeting. Hang on a second. I just want to share the meeting one again. And it's taking a while. Okay, we were stuck at the agenda last time. Let's just move on to this meeting. Okay, so we've seen the minutes of the previous meeting. Are there any changes that anybody wants to make to the minutes? Please raise your hand so that I can see. Going once. Beverly, I'm going to unmute you. Yes, you could speak. Okay, seems that. Okay, so if there's no changes, can I have acceptance of the minutes? One person to actually propose is the right word, to propose the minutes. Beverly, thank you. Is that what you tried to do? Thank you, Beverly. And a second person to second it, Yolandi Jooste. Thank you for seconding, Yolandi. Adele, I hand over to you to present the finances.
Good day, Janet and members. The financials on the 5th of the 5th is standing on a healthy balance of 205,886 and 25 cents. Our workshop brought in a profit from just over 15,000. And yes, if there's any questions about the financial statement, rather ask me and then I can have a look for you. But yes, I'm happy to say that our finances is in a healthy state.
Thank you,
That's it,
Adele.
Janet.
Thank you. And can I have one member to accept the financial report? Thank you, Beverly Buter. And one person to second it. Thank you, Yolandi and Sandra. Sandra, we don't have your surname. I think we'll find it in the minutes. Oh, sorry, in the chat. Thank you. Okay. It's the finances are approved. Thank you very much. Adele, you can give us feedback on the academic day. I've included a few pictures for you. Adele was there as an observer, and she also attended the academic day as a sponsored member because she was there. We can tell you it was a great success. It was hosted in Gauteng. So Adele, I'll hand over to you.
Yes, hi. So the EXCO meeting was held on the 7th and the 9th, and the academic day on the 8th. I just want to say a few words. I think I want to say, under the leadership of Joan Visser, it was a very valuable meeting. I could see the many hours of dedication that all the EXCO office bearers are putting in. The meetings were structured and the rules of procedure were followed. What was noticeable to me was that we are focusing on the smaller regions to help them to grow stronger and to grow their membership. So, and then maybe, the bridge minutes from the EXCO meeting will give some more info on the current issues that were there on the table. And then on the 8th of May, I attended the academic day at UJ. The theme was Innovating Workplace Wellness, Tools for the Future, focusing on the latest advancements, trends, and best practices in occupational health. A few highlights of the day was it started off with the esteemed Professor Judy Bruce. She spoke about the evolving landscape of the nursing and how we as OSNPs are shaping the future of occupational health in the workplace. She introduced us the website named JOOL. It is Caregiving in Crisis. Here is why we need a new approach. That is as per the JOOL website. I found it on LinkedIn. Then secondly, Dr. David Mkwanasi talked about AI and how it will be transforming our lives. He mentioned an app such as Earscope, which is a digital video otoscope that can capture high quality images and help us with the diagnosis. Then Denise Minnie, always inspiring, she gave a presentation about in a world where uncertainty is constant, and we as occupational health nurses, she said we need to adapt. We are being called to lead. We are no longer just responders or caregivers, we are advocates, innovators. A topic that I found very interesting was psychologist Chantal Moodley. She works in a bariatric unit where she says we as OHNPs need to be aware that our patients not only sometimes waiting gain weight is not only for not trying to eat healthy, but there are other disruptions, biological processes. She mentioned, for example, leptin resistance, where the brain doesn't recognize the satiety levels. Or then we all know about the insulin resistance that can lead to increased fat storage. Vernon Pillay is a lawyer that gave very interesting case studies and legal challenges, practical examples. And the highlight of the day was Namsha Mapawuku. She gave an exceptional motivational talk. She called it Seat at the Table, referring to women making an impact in the business world. So well done to West for hosting such a successful academic day. That's it, Joannette.
Thank you, Adele. Next up is Lindy to give us feedback on whole portfolios. Lindy, I hand over to you. You can share your screen.
Thank you, Joannette. Let me just make sure I'm sharing the correct screen. Sorry, this one. Right, so let's just have a look quickly. For today, we had Professor David Rees with the respiratory impairment and some back to basics. Thank you, Joannette, on the eye conditions. And those will then be shared. Professor Rees did give permission, so we will share that. And then in June, we'll have a mini virtual workshop on the 25th of June. It is a Wednesday afternoon from 1 to 4. And we are, as I am speaking to you, confirming the speakers, and we will circulate that information. And then July, we will have on the 30th of July our next general meeting. So no general meeting in June because of the mini virtual workshop. Then for the health calendar, I'm just highlighting the 16th of June. Oh, Janet, can you still hear me?
Yes, I can hear you. Oh, you're gone now.
Janet?
Yes, there you go. And there she's gone again. Lindy, it seems that there's a issue with your sound. Okay, let's just give Lindy a minute. I'm going to go on with my presentation until she can join again. Give me a second. I'm sharing out of PowerPoint, so it's sometimes a little bit slow. Okay. Paula, if you're in the meeting, you can continue. Okay, it looks like he was kicked off as well. So just to quickly tell you, Paula have managed to get an appointment with one of the chief inspectors of the Department of Employment and Labour, and he's setting up a meeting for June, me, him, and the chief inspector, where we will discuss a few of the issues that we've been having in the region. If there is anything on your side that is of a specific concern, please let us know on the WhatsApp group so that we can raise it while we are there. Okay, then Beverly, you can continue with your feedback.
Okay, good afternoon, everybody. Social responsibility. We have the one project, it's the Somerset West Family Shelter. It's one of a kind in the country, a non-government organization, and families are referred by the Department of Social Welfare or social workers. And these families are allowed to stay for up to 1 year at this shelter, and they are then helped back into society with employment or a place of abode, and they help with skills to help their families to survive. So this shelter survives on donations: linen, clothes, toiletries, face cloths, nappies for children, and also food. There's also a creche with 13 children currently on site, and children are also taken to school daily. So how can we assess on help? And we need contributions. Please feel free to contact me on the WhatsApp group. I'll be happy to come and collect. Donate clothes or linen that you're not using anymore, toiletries, face cloths, nappies, or we could do a sanitary towel drive, which is always helpful. And or you could call your caregiver or committee member close to you if you have something to donate, and we can arrange for collection and delivery. And then there's also, we're continuing with the knitters. They are making wonderful little things for the babies in hospitals, and they deliver to many different places who need knitting. So yeah, please feel free. I've already had somebody ask me if there's a child size 1 shoe that you're not using, a tacky or something, a child needs it. So I've been looking around. And then whatever you have to donate, we'll greatly appreciate it. Thank you very much. Over to you, Janet.
Thank you, Beverly. Lindy, I see you are back. You're welcome to continue your presentation.
Okay, thank you, Joanette. Yeah, just got kicked out. I think I was last year at the health calendar. Just want to highlight at 16th of June, the Monday is Youth Day. And then we have our Sanka Drug Awareness Week, the 22nd to 27th of June, with the International Day Against Drug Abuse and Illicit Trafficking on the 26th. Upcoming courses, I've got Health Science Academy. They've got face-to-face as well as virtual courses. They've got audiometry, spiro, and vision in June. And they've got dispensing, it seems every month, and then also the refresher courses, which is available on demand anytime, and then in Pretoria in June for audio and spiro. EFHA, they've got audio, spiro, and vision every month except December, and the refreshers for the year, there's one for audio, vision, and then reproductive health, as well as spirometry. Those are the dates, the only dates for refreshers for the rest of the year. Right, there's an upcoming webinar. After this meeting, I will share you the information that you can register. It's about ergonomics. I think it might be a very good 1,800 to spend on this. Yeah, I'll share the program with you. And then for our students that are online, or for our other OHPs that have peers that mentor them and assist them, I think it's by July, the committee needs to have received nominations for the Session Mentor of the Year. The purpose of this is to honor our mentors. I think you all know, we've all been there. We need to start somewhere. We need somebody to help us and guide us. And this is the way of honoring them. So there is a procedure that we have to follow. And if you want more information, please contact me, and I will share it with you. And let's nominate mentors for the year. Then our CPD points for the March workshop was just received this morning, so I will do the certificates as soon as possible. And as you all know, we're still waiting for SANG to implement the CPD system for the nurses. A little bit about the mini virtual workshop. I did speak about it in the first slide. It will be on mental health. The cost would be 350 Rand for a member, 450 Rand for a non-member. Please, you can also apply for sponsorship if you want to join this. It's going to be a very exciting workshop, and we are really trying to give something back to the occupational health practitioner. So hence my question for today. Do you feel equipped to recognize and respond to the early signs of mental health challenges in your workplace before they impact the safety, productivity, and employee well-being? And are you prepared to facilitate a safe and supportive return to work process for the employees recovering from mental health challenges? And the last one, how can you effectively support the mental health of others in the workplace if you're not protecting your own well-being as an occupational health practitioner? So these are some of the questions we will be answering in the workshop, And I want to give you one of the answers so long as a teaser. So the early identification by the OC health nurse is observing behavioral changes. I do know if you have an off-site clinic, this is not always possible, but for those of you who have got on-site clinic and you know your employees very well, usually the managers will complain of a sudden drop in work performance, increase in absenteeism or sick leave if you do receive those notifications and reports. They might withdraw from colleagues or workplace activities, be irritable, mood swings or emotional outputs, and signs of fatigue, poor concentration or indecisiveness. In the clinic, we will get the complaints of the headaches, muscle tension, GI issues. If you have read the newsletter, you would see Joanette has written something about primary healthcare and in the occupational healthcare setup. And these are the things that we will pick up when they come with primary healthcare complaints. Maybe some sleep disturbances, appearing constantly tired, have some weight loss or weight gain. And we are all very good at non-verbal or verbal cues. When your employee is sitting there, you are doing your health assessment and they're feeling overwhelmed or hopeless or a little bit anxious. Can you then identify the burnout, the anxiety, and the depression that might be luring? So have a look at the patterns of frequent or unexplained absenteeism, maybe some increase in injury on duties. And this is where we need to build those trusting relationships, creating the safe space where our employees can come and talk to us. And hopefully there's a very good employee wellness program in place where you can refer these employees and make a difference, because I do also acknowledge that we do not always have the time to go in depth with this, but we need to recognize it and we need to have something in place to assist this employee, if it is referral or whatever procedure is in your specific company. So that's all from me. Thank you. And we'll see you on the 25th of June at the workshop.
Thank you, Lindy. Let's just get back to the presentation. As always, it takes a little bit of time. I'm sorry about that. They say the speed of light is so fast that it travels around the world 7 times in 1 second. So this would have been around the world a few times. Okay, so EXCO feedback. I did mention last time that we've received the task of reviewing the guidelines of risk assessment, how to write a business plan and establishing an OH clinic. I did post a poll earlier to ask members who want to contribute towards reviewing this. Hopefully it will not be a very long process, 1 or 2 meetings for each guidelines. I also invited observers and students to join where they can. It's always an eye-opener to look at a guideline in depth, and reviewing it's a very good opportunity to do that. I'm still looking for people who can contribute to this, especially with regards to, I think, the business plan. If you have written a business plan before, if you are confident in doing so, please reach out so that we can make use of your expertise. And then they also, with the last EXCO meeting, I took the question of the salary survey to EXCO as requested, and I have tasked the Western Cape to redo the salary survey. I am still trying to get information from companies like Deloitte on how they gauge salaries. I know my company is using them to determine the salaries for all the staff, and obviously they have a lot of information with regards to the issues and the different types of salaries. If there's anything that any of you can contribute, you are welcome to contact me. Thank you very much. Thank you. And then the newsletter. We have decided, I'm the unfortunate winner of the newsletter. And when I did the last one, I realized, but there's so much more that we can do on the newsletter. Can you see my screen, Lindy?
Yes, I can.
Oh, okay, wonderful. Okay. There's so much more that we can do in the newsletter, but then it requires a little bit more frequent issuing, and they have agreed that we can issue 1 newsletter every quarter. Again, it was assigned to me, and I'm going to need your help. Anybody that can contribute towards the newsletter, articles or photos or anything that you want to share, please do so. See, the few people can't see my screen. Let me just start closing windows. Apparently that helps. I've got 2 million windows open.
I can't share and just share again, Janet, because I can't see, so I don't know what is the issue.
So hang on a sec. I'm in the process of resharing. And there we go. So
Right, I can see.
Okay, good. Hopefully everybody is now able to see. And then the academic day, the Western Cape was assigned the academic day for 2026. Our theme is Christmas and winter, which is very nice. I hope that we will be able to give them the theme in May that we want. If this May is any indication, it will hopefully be cold enough for that. All right, and then keeping in touch with members, very important that you make use of the WhatsApp group, because as I say, we're not sending out emails any longer. And if you are not added to the WhatsApp group, please contact your caregiver. All communication that was previously sent via email will now be shared on WhatsApp. And there's also a new feature on WhatsApp where we can put an invitation on for meetings or events. Please keep an eye out for that. We will pin it to the top if it's something that is planned ahead of time. The link to the Teams meetings will also be in there, and as I said, it's usually pinned to the top. All right, and then if you are interested, let me just get back to the chat. If you are interested in presenting at any of our meetings, please do so. Please volunteer for that. We've got several options for back to basics, general meetings or workshops, and we are always looking for competent presenters or people whose area of expertise this is. So there's a little poll. If you can present any of this and you can click more than one option, please submit that. Otherwise, just send me an email if you are interested. I want to get it off my screen. There you go. Thank you. Okay, this is the WhatsApp group. The QR code for the WhatsApp group. I've pinned it in the chat. So if you are not fast enough to scan it now, you will be able to get it in the chat even after the meeting is ended. Just note that it's an exclusive group. You have to be a SASHON member, a full SASHON member, a Western Cape member to belong to this group. If you apply for membership, or sorry, to belong to the group, you will be put on hold until one of the committee members can verify your membership. Don't be angry with us for that. That's the only reason that we can keep this group exclusive. And then also, lastly, I want to thank Dorothy and Serenity for your hard work behind the scenes. Serenity has decided to withdraw from the committee due to personal commitments, and we thank her for everything she has done up to now. Serenity, we are going to really, really miss you. So thank you for everything you have done, and we will definitely fill the gap at our next meeting. Okay, so due to Serenity's departure, we have changed the caregivers group. It's also pinned on top of the WhatsApp chat. So if you can't see it now, please just go to WhatsApp chat. Paula's taken over Serenity's list. He's now responsible for people, all surnames starting between A and F. Thank you, Paula, for taking that up. The rest stays the same. And then on the screen is the contact numbers for membership, SASHON head office, and the audios. Please note it's 2 different email addresses, 2 different cell phone numbers. If you need to contact somebody, make sure that you contact Adele for the membership on office at SASHON. And if it's audio membership, that there is any questions on, then contact Gita on audio@sashon.co.za. I will, for all those of you who struggle seeing the screen, I will share all of this in the chat as well. And then lastly, thank you everybody for attending. It was great to see you here. And if there's anything we can help you with or that you need assistance with, please reach out to your caregiver. And if they can't help you, then they will escalate it to the committee. Thank you very much. Is there any questions, any comments? Anybody that wants to add something? Beverly, let me just enable your mic. You can unmute and speak.
Thanks, Jeanette. Well, you ladies have really raised the bar with Teams and your IT skills. I feel quite out of my depth. Fortunately, you just send the link and I say click here and I click and I wait for things to happen. But thank you very much. I can see a lot of effort has gone in and I'm sure the rest of the members will agree. Just a thought that if by way of maybe some people don't come forward for presentations, I particularly see this whole system as very intimidating because it's just so new to me. But would at some point maybe just in back to basics help us with some guidance on how we upload slides on here and that kind of thing? Is that a possibility?
Yes, definitely. Upload slides where?
Onto Teams, like you've done
Teams.
this afternoon. Yeah, just so that we get an idea of how does this get navigated.
Sure.
You know, I'm still old school where I worked off PowerPoint and did a couple of slides to put together and present. But where's the link? How do you get it onto Teams? Because it seems quite a complex challenge.
It's actually not. It's actually easy. But we will definitely keep that in mind for B2B. Somebody just has to show you, that's all.
Yeah.
Like that to show me.
Yeah. Okay.
Okay. Thank you, Beverly, for that. Lindy will make a notice of that. Thank you, everybody, for joining. And I declare the meeting closed. We hope to see you next time. Goodbye. The committee can just say behind, please.